warm welcome to everybody in attendance. So my name is Laura McLean and I am the chair of this Health Scrutiny subcommittee. So before we get going, Sam is going to read the housekeeping arrangements for us.
Thank you, Chair. Please can I request that mobile telephones and other such equipment are switched to silent mode so as not to disturb the conduct of the meeting. Which does remind me I need to do that with my own. There we go. There is no fire test planned for today. If there is an emergency evacuation, please take instruction from the council staff present. The assembly point is in Tudor Square. The meeting today is open to the public and will be streamed live and for subsequent broadcast via the council's website. You should be aware that the council is a data controller under the Data Protection Act. Data collected during this webcast will be retained in accordance with the council's published policy. By entering the meeting room, you are consenting to be filmed and to the possible use of those images and sound recordings for webcasting. Thank you, Chair.
Great, thank you. Can I please ask that members and officers introduce themselves, starting with Councillor Milsom on my left? Thank you.
Good morning, Councillor Ruth Milsom.
Morning from Belbin, Councillor for Firth Park Wards.
Good morning, Councillor Mary Lee, Darnell Ward.
Morning, Councillor Toby Mallinson, Hillsborough and Green Party spokesperson.
Councillor Steve Harrison, Deputy Chair of Health Scrutiny Subcommittee.
Councillor Penny Baker, Councillor Stamington Ward.
Councillor Sophie Crossthorne for Beechif and Greenall Ward.
Sam Walstow, Democratic Services.
Alice Nicholson, Policy and Improvement Officer.
Deborah Glenn, Policy and Improvement Officer, just here to observe today.
Great, thanks to you.
Laura,
also got,
And Laura Cook, Head of Health Watch Sheffield.
Brilliant, thank you. So the next item is apologies, but I don't believe we have any this morning. And then our next item is if we had any items to be excluded from the public and the press, but again, there aren't any. So the next item, item 3, is declarations of interest. So can I ask whether there are any members that wish to declare an interest in any of the items of business today? Nope, brilliant. So the next item would be our minutes of our previous meeting, but these haven't been prepared yet. So in our meeting in March, we will consider both sets of minutes for this meeting and the last one in December. So we'll move on to our next item, which is item 5, public questions, statements and petitions. We've got some public questions today, so I'll just ask Dr. Gibson to come and join us for his question.
Other side.
Okay.
Good morning. So welcome, Dr. Gibson. So you came to our meeting in December with a question which I answered in writing since then, and so you've come today to ask a supplementary question. So if you'd like to do that, that would be great. Thank you.
Good morning, subcommittee. So, Dr. Rory Gibson, resident doctor and a member of the campaign group MedAct. So, our campaign appreciates the subcommittee's response to our question. We appreciate the subcommittee does not have the remit to scrutinise a national NHS contract with Palantir. However, we do feel the subcommittee could provide an opinion whether the systems associated with that contract are adopted locally and included within local data policy. As mentioned previously, the adoption of the Federated Data Platform is not currently mandatory, as demonstrated by Greater Manchester ICB's decision to pause uptake. We are aware no patient data within the ICB currently flows into the FDP, but we demand a commitment that no data ever flows into the FDP whilst involving technologies owned by Palantir in its current position. As discussed, it enables a company facing human rights abuse allegations. It risks eroding data privacy and patient trust in health data systems and continues NHS privatisation. It also concerns national and local data sovereignty, risking vendor lock-in and indefinite reliance on US-based Palantir for health data processing. Does the subcommittee support our campaign's demand that the uptake of the FDP should be paused and opposed locally, and that the ICB and local health trusts commit to no patient data ever flowing into the FDP during Palantir's involvement? Thank you.
Thank you. So thank you for coming today to bring your question. So in my answer to your original question, I explained that I will follow up and inquire with the South Yorkshire ICB in regard to any future plans for the FDP locally, requesting an update on its use, but also the overall approach to handling of AI in the Sheffield health system. So this subcommittee would not be able to take a view of any potential rollout of the FDP without fully exercising our powers of review and scrutiny. So later on this morning in this meeting under agenda item 8, we will have the opportunity to discuss items that we might want to add as a committee to our work programme. So I will raise this then with the rest of the committee as a potential future item. So thank you so much for coming today. And like I said to you in December, it's always really good when members of the public do come to these meetings. And it's not just us start discussing things amongst ourselves. So really appreciate that. Thank you for your time.
I guess without all that information being fully available now, will there be an opportunity to ask a supplementary to the supplementary once that data is available?
You're welcome to come back and ask a further question in the future. It's a brand new question, yeah. That's not a problem. Thank you. Brilliant. We've had a couple more questions, so I'll just move.
Could I just ask about that? Will there be an opportunity for the subcommittee to, well, I know we're going to discuss it under the work programme, but just while Dr Gibson's still here in case he needs to go, will there be a chance for us to actually explore the background to the Palantir platform, and it's just for Dr Gibson's benefit while he's here to hear us, really.
Sorry.
Is that something the subcommittee can do?
The questions is just response and answer.
Yeah,
so.
the advice we're giving that public questions are just a response and a response to the question, and that the discussion needs to take place under the work programme. That's where we add items to the committee.
Just aware of his time.
Thank you. So the second question we've received, I'm going to just read out because the questioner hasn't been able to make it today. So we received a second question from Mr Hassan, and I'm going to read that question now. So today's meeting, does the council verify qualifications, references of its employee during appointment, or can probation period be extended? HR matter as council trained. How long will upgraded process of the property shop be? Can the council homeless scheme be reviewed? Is the NHS Northern General reliable? Can the HSF scheme be extended due to the increased cost of living? So we received this question and these questions, and we're going to provide a full response to the questionnaire, and that will be published on the council's website. So I'll move on to our last public question, and that came from Megan Jones-Davies. And again, she's not here to ask that question today, so I will read it out and also my answer, because again, this may be relevant to our work programme item later on the agenda. And so the question is, she talks about a report, and that's a report from the charity SANS about that the SANS and bereaved parents have put together. And that report has been circulated to committee members ahead of today's meeting. So I'll begin with her question. The report the question refers to is regarding the one that me and other bereaved parents put together with the support of the SANS charity. Our recent report shows that bereaved parents in Sheffield are not receiving adequate support following the loss of their baby. Jessop's put this down to lack of funding. Are there plans to look at the budget and consider more support in this area? How can us, as a campaign team for SANS, support local councillors to make positive changes in this area? There has been insufficient improvement in bereavement and health services at Sheffield Hospital. How can bereavement care be made more of a priority in maternity services? And so I'll now move on to my response. Thank you for your questions. You ask how you, SANS, as a campaign team, can support local councillors to make positive changes. You have started by sending the report, Bereavement Care in South Yorkshire, that we have circulated to Sheffield Health Scrutiny subcommittee members and for information to councillor colleagues in a wider geography, as your report is not exclusively to Sheffield, but to members of the South Yorkshire, Derbyshire and Nottinghamshire Joint Health Overview and Scrutiny Committee. You ask questions to this committee in regard to bereavement and mental health services at Sheffield hospitals, in particular the maternity services for bereaved parents in Sheffield following the loss of their baby. The questions you raise are best answered by the Commissioner and provider of these services, in this case the ICB and Sheffield Teaching Hospitals. As a committee, we have the opportunity to decide whether we should consider for inclusion in our work programme an item on the provision and operation of the local NHS service, in this case, bereavement and mental health services. We would invite all interested parties, including SANS, health commissioners and providers. So that takes us to the end of our item of public questions, and there were no statements or petitions. Toby.
Thanks, Chair. Yeah, just on that last one, was there a discussion about putting that on, or having a discussion about putting that on the work programme? Did you just say that? Sorry.
Yes, so we'll do that in the work programming section,
Okay,
but yes.
thank you.
And so we'll move on to members' questions, and again, we haven't received any of those today. So that brings us on to our substantive item 7, about primary medical services update. So I'll ask Abigail to introduce herself and do her presentation. Thank you.
Thank you. My name's Abigail Tabbs and I'm Assistant Director of Transformation and Delivery. I lead on primary care for Sheffield Place within South Yorkshire ICB. We've been asked by the committee to provide an update today, and there were 2 items of particular interest. One was about neighbourhood models, including city centre capacity and provision, and the second was around access to appointments and booking systems. So this report, the report I'm presenting today, covers both of those areas. Councillors may be aware that will obviously be aware of the NHS England guidelines published earlier last year, 2025, around neighbourhood health model. In Sheffield, we continue to develop that model, and there will be a paper being presented to the Sheffield Health and Social Care Board in February. Once that's been presented, I'd be happy to come here to share that and discuss it further. However, I can provide more of an update on capacity planning work around the city centre, which is related to discussions that we have brought here previously around plans to develop 3 new health centres in the city, one of which, the Foundry Hub, is very close to completion. The other one that with our delivery partner, who is Sheffield City Council. The other one that relates to the city centre hub, hasn't progressed at the same speed. We are still finalising legal arrangements around the acquisition of the property. So we can provide an update once that process is complete. It's worth drawing people's attention to the assumptions that have been set out in the paper in terms of the limitations of capacity planning in this space. So there's a couple of things here. We have based our work around what we know is likely to be the continuing population growth and development from the latest iteration of the council's integrated delivery plan. So based on that, we believe that by 2035 we can expect around just short of 30,000 additional residents in the city centre. However, we are also operating at a time, and we'll sort of come on in part to that later, where we're seeing change in models of service delivery. So obviously the increasing adoption of a sort of digital first approach and the sort of variable adoption of that by different cohorts of the population will obviously have an impact on the capacity required in terms of the amount of physical space, but also the type of space. So, for example, in an increasing number of practices, we're seeing people not just asking for physical consulting rooms, but spaces that are appropriate to undertake telephone consultations as well, because practices historically haven't been well equipped for that. And the other issue that we have to bear in mind is choice. So provided you live within the catchment area of a GP practice, you can register with that practice. And it isn't for us as an ICB to seek to control that. Patients are free to exercise that choice. And indeed, in some cases, practices will allow patients to register if they live outside their catchment area. So we can look at the overall and we can look at what the sum total of individual practices is, but we can't be absolutely certain that individual, at this point, that individual practice capacity is sufficient, if that's clear. So obviously we've set out the sort of assumptions that we've used in terms of this modelling, and you can see from the table in section 2.3, we've looked at, for this question, at the 10 practices that have a catchment that covers all or part of the city centre. And we have looked at their current list sizes, their existing physical capacity, so the number of rooms they've got, and we have also included the number of new or planned rooms, so that's either developments we've completed recently supporting practices or developments that are planned within the next 12 months. So that includes obviously the development for Sheffield Medical Centre and Burngreave, which is the new Foundry, what we call the Foundry One hub. And it also, for Clover City practice and Mulberry practice, it includes what will be the new city centre hub. And you can see from that that overall for those 10 practices, there are a total of 41 additional either new now or planned rooms for clinical work. And we've therefore been able to extrapolate from that what we think the potential capacity those practices could serve with that space are. And you'll see from that overall, within the caveats I've given you, we should have sufficient capacity within existing practices for the current forecast growth. The one exception to that is Kelham Island, where we don't currently, because of the sort of history of that area being an industrial area, we don't currently have physical GP premises in that location, which is why we've put that forward for consideration as part of community infrastructure levy for any new developments, because we think that's probably the one point where we'd need either new premises or a new practice to ensure that services are accessible. But as I said before, caveat that with, that's assuming that people register broadly where we expect them to register. And that may not be the case. So we need to we will continue to monitor that. We monitor list sizes and capacity routinely, and we'll continue to monitor that as part of our sort of primary care commissioning role and as part of the work we do on primary care estates. Would it be sensible just to stop there and see if there are any questions on that element before moving on to the other section?
That would be fine with me, yeah, definitely. Any questions? Councillor Harris.
Thank you, Chair. Thank you, Abigail. I just wanted to ask a question about the progress on the city centre hub, and you said that that there would be. First question is this part of the report that's going to the Sheffield Health and Social Care Board? And what I'm trying to explore is what the time scale for when we might be able to have an update on this. I mean, the last report that came to us as a council scrutiny subcommittee is going back almost 18 months, probably longer than that. And at that point in time, and I think since then, since that point, we had small updates that the planning, the listed building consent for the Royal Bank of Scotland building on Church Street had been approved and the conditions had been met under that application. So one of the questions is that building still secure, and or is that still in the mix in terms of progress on creating a city centre hub?
Absolutely. It is that building, when I say that we are working with the council, it is that building that we are hoping to finalise the legal agreements for purchase of as soon as possible. So that's the building we're talking about. That won't be part of the paper to health scrutiny. That's about the neighbourhood. That's about neighbourhood healthcare. As soon as we have completed that legal work, we'll be happy to bring an update in terms of the timelines for completing that development.
Sorry to jump in, Abigail, but the reason that I asked that question is because there's a time limit on planning approval.
We're aware of that, yeah. So if you're happy, I hope we might be able to bring that reasonably soon, but obviously I can't go into sort of the details of the legal discussions going on.
I appreciate that. Councillor Milson, have you got a question?
Thank you. Yes, I do. Yes. Hello, Abby.
Hi.
So, if we're just talking about capacity and estate, essentially, at this point. So, Callum Island and Neepsend, I don't know. It seems quite concerning that it's only just going into consideration that there should be a surgery there. So the developments there, I think, from memory, have been taking place since sort of 2010.
Yes.
So how are we kind of 15 years down the line and just about considering a surgery?
So
I mean,
we are aware that we have been aware for some time that one of the likely results of continued development there is the need for a surgery. And that's why at this point we're putting it in as a part of the SIL discussion for future development, but it has been part of our longer term consideration in terms of capacity and development.
what are the factors that kind of that will allow that to happen or not? Because I mean, if a whole new community is built all at once, then there's a master plan, and
yes,
and surgeries are built into
absolutely.
that, and especially with the assurances of the golden rules now for developments, and the infrastructure has to come with. Now maybe there's a bit more hope with that, but when a neighbourhood comes up in dribs and drabs over 15 years, it's obviously much harder to achieve the money for that, essentially, isn't it? Because it's multiple developers who have done small things and there's no demand on them to provide anything. So it seems like a big risk for health, the way that kind of development springs up over time. So is there anything you can do to mitigate that, given that Sheffield is going to continue growing? Is there something different? Is there some different way of getting ahead of the curve, as it were, where there are going to be smaller developments that increase population?
So those developments we consider it through the planning process, but we also have a strategic estates group within Sheffield. The council, all our provider trusts are members of that. The NHS Property Services, our local lift company, and other key players in the sort of public sector infrastructure. We use that to consider overall the public estate as it relates to healthcare and what the opportunities are within that, and also what we think is happening in terms of longer term population change. And then as an ICB, in terms of primary care estate, we're also have developed are in the process of developing a 5-year pipeline for the capital we do have, to make sure we're targeting that to those areas where we know we need most, where the issues are most pressing. But the capital we have available is relatively limited for primary care development. But that doesn't, well, the other thing we have to bear in mind is what I've said earlier, is that use of health services is changing, and the models of delivery for primary care services are changing and will continue to change over time. So we're sort of seeing the move towards digital first, towards online consultation, telephone consultation. We have to make sure that our services are inclusive for all, including those who aren't, as able to or happy to use digital services. But the sort of longer term forecast is that the demand for digital is likely to increase because the younger population is more ready to adopt that. So we've got to factor in those changes as well, which mean changes not only to the size of practices, but to the type of provision we're making available.
Yeah, I totally hear that about the digital transformation, but it's still the GP patient ratio is still a consideration, however people are accessing.
Not just the GP patient
GP.
ratio, because we have a very large workforce in primary care. So it's not just GPs, nurses, healthcare assistants, physios, pharmacists, AMPs. So it's that wider workforce as well that we're planning for.
So it's the physical capacity in buildings, whether people attend them. So I guess what I'm saying is GPs still need to work from somewhere, even if they're doing a phone consultation.
Yes, they do, although the configuration of that space, if you're using it exclusively for phone consultations, and the amount of space you need is very different to the space you need for a physical consulting room. So, for example, we know that you could probably accommodate 2 or possibly 3 people to undertake telephone consultations in the same space you'd need for a modern accessible consulting room.
Thanks. Can I ask a question? In terms of Kelham Island at the moment, in the patient voice, do you hear from residents in Kelham Island that they want a surgery? Do they feel that lack already at the moment, or?
We haven't heard at a large scale specifically from Kelham Island. And I think one of the things we would want to do is understand people's preferences if we came to planning something. But we do know that the practices in the surrounding area receive a lot of registrations from there, obviously.
Thank you. Laura Cook, have you got a question?
Yeah, I was just going to ask about workforce actually, because obviously the adoption of digital first models and like the additional rooms are great in terms of creating capacity, but what's the sort of workforce plan that's going to complement that and make that a reality?
Longer term workforce plans aren't something that I've brought the detail on here. What we do know and what we are working with is current workforce plans and the short term plans. We have seen quite a large growth in the broader primary care workforce in the last few years through the additional roles that have been introduced into primary care networks, and those changes obviously meant meant quite a lot of quite a lot of juggling to find additional capacity. In terms of longer term workforce planning, that's something that we are seeking to build in alongside the sort of longer term capacity planning. But obviously some of that is outside the ICB's, a lot of that is outside the ICB's direct gift, because, for example, GP workforce planning doesn't sit with us. We can look at what we think is needed for the population, but the actual workforce planning element of it, we have to engage with others around.
Councillor Mallinson.
Thank you. Thanks for the update as well. I think it sounds like there's a lot of good amount of work going on to plan ahead. I'm sort of curious about the planning ahead and the process of that, because you can't make detailed plans for many years in advance because you don't know what is actually going to happen. It could be a waste of effort. But on the other hand, so I'm just curious about how far ahead do you look for your detailed plans? For example, there's plans, whether they come to fruition, to develop Moorfoot, which would be a lot of accommodation in that area, which could overwhelm local GP practices in that area, much like you're talking about Kelham Island. Obviously you need to have detailed plan or be planning things in time from knowing that that's going to be happening, to have a time scale where you can get a service in there if needed, and recruit people or set it up so it will be there. So how far ahead do you look?
That's a good point. So at the moment, we are the work I've described here around the city centre up until 2035. We've actually that work is expanded. So we're trying to look at the whole of Sheffield in terms of the need up to 2035. But as you said, at this point, we can plan for, in more detail for the next 5 years, but we need to have that horizon scanning for the next 10 or 15 so that we know where we think there might be significant pinch points. More foot, actually, one of the reasons we've just recently completed a development for Steel City Practice who've moved into St Mary's from Shoreham Street, and actually they're like the anticipated growth in that area of the city centre was one of the motivating factors around that development.
Councillor Costello.
Thank you. I appreciate I can only speak from my own experience on this as someone who previously lived in Kelham Island, but I accessed Upperthorpe Medical Centre at the time, and I think a lot of people do. I can only stress that I've experienced really, really good and timely care there.
Really
and certainly when we're looking at the development of a further medical centre in Kelham Island, looking at that in terms of the spatial, because it was in walking distance for me where I lived at the time, but the further obviously into Kelham Island you get, the more inaccessible that becomes. So I hope that's something that will be taken into consideration there. I just wanted to go back to the city centre hub, if that's okay. You said that that's not progressed at the same speed due to legal issues with land acquisition. I appreciate you can't go into detail on legal discussions, but could you explain to me, as if I was a lay person watching this webcast, what that means and what that delay is, what end does that concern, and what can we do as a council to help get that back on track?
So we are already working with you as a council. You are our delivery partner for all 3 of the hubs. So your legal teams and property teams are very involved in this work already. It's the acquisition of a property, and it's the process of finalising some of the necessary arrangements for that. I really can't go into any further detail at this point.
Thank you. Councillor Lee, did you have a question?
Thanks a lot for your report so far. Obviously demand will rise because Kelham Island, you're considering Kelham Island, and we know the population in the city centre is really going to surge. So demand is there, and you're planning for physical services and buildings. How about supply of professionals to those services? Is that something that you're concerned about? And I'm talking about in the next 5-10 years, not just immediately.
Yeah, I think I've referred to the sort of workforce planning and what needs to happen around workforce planning, or what does happen around workforce planning alongside that. Obviously, as an ICB, we work alongside NHS England and others to try and ensure that workforce pipeline is there to meet the needs of the projected needs of our population.
So you're confident that the supply of people will be there? And I'm just thinking as well, impact across the city, because we know population that we've just had long discussions on the local plan, and we know where houses will be built, possibly, and we know services are needed,
So that's part of, I referred to the work we've done in the work you see here for Sheffield City Centre. We are looking at across the whole of the city, so looking where we know there will be development, where we know practices lists are growing, and understanding the reasons why and what we think those changes are going to be, not through population movement and new housing developments. Yeah.
And you've got a plan.
Well,
planning, but
a plan is emerging. Yes.
Great, thank you. Should we move on to the next section of the report?
Thank you.
Thank you, Abigail.
So the second section was just an update for the committee on the changes to the GP contract that were implemented from the 1st of October. Specifically those areas which relate directly to patient access and booking of appointments. So from the 1st of October, there were a number of changes to the GP contract, the most obvious of which is around mandating the availability of online consultation tools. So members of the committee might have used these. So this is when you can go onto the website and submit, using an online consultation tool, submit a request to your GP practice. And the objective of mandating the use of online consultation is to try and reduce the what's widely referred to as the 8 a.m. rush. So everybody jumping on the phone at 8 o'clock in the morning to try and get an appointment with their GP practice. In addition to that, a firming up of the requirements that effectively creates parity of access. So parity of access regardless of whether you choose to walk into your GP practice, you phone your GP practice, or you use online consultation. So the expectation, your practice should be open from 8 to 6:30 Monday to Friday, and you can access the same level of, that you have the same level of accessibility whichever of those modes you choose to use. All practices in Sheffield do have an appropriate online consultation tool. You will appreciate, given the variation in size of practices and the fact that all practices are independent and therefore run, there are differences in how practices choose to operate their internal systems, that it is not necessarily going to be an immediate change. A practice isn't necessarily immediately able, if they haven't been using online consultation, some practices have for quite some time, to switch suddenly to having online consultation on 8 till 6:30. That is something we are working with practices on. We have reviewed all practices' access, and we are offering support to practices to get them in the place they need to be contractually compliant on this. So that would be all practices in Sheffield we are working with to support on that. I also added into here just a little section on you and your general practice, which is a new way NHS England have developed for patients to give feedback on practices. So it sits outside the complaint process, and it's a route for it's two things. It's one is sort of explaining what you can expect from your practice, and also what you can do to support your practice. So for example, giving adequate notice if you can't attend an appointment, so they can offer that to somebody else, but also giving a route to provide feedback, be that positive or sort of hopefully constructive feedback on where patients think that can be improved. All practices have a link to you and your general practice on their websites, and in addition the ICB has a route through our website where patients can provide feedback if they would prefer to use that route, which we will then sort of review for themes but also share with individual practices. So hopefully that will become an additional route whereby practices can obtain views from their patients, in addition to patient participation groups and seeking feedback through other routes. I also just for the committee's interest, I've just added a very brief update in there around additional steps that the ICB's taken to increase capacity, particularly over the winter period as part of our Sheffield Winter Plan. So we commission an urgent same-day primary care service, which is an addition to the primary care network provided enhanced access services, and that is to support practices with that urgent same-day capacity. When they're seeing patients who need to be seen on the day, they can book into that service, which is offered from 2 hubs by Primary Care Sheffield across the city. And what we do with that service is we step it up significantly. We have a level of service that continues throughout the year, but we step that up significantly in the winter when we know, there's going to be more demand, particularly for patients with respiratory issues. We've also funded an additional late blood collection from a number of practices that the aim of which is to ensure that you can manage blood tests better throughout the day rather than having to get all those done sort of first thing in the morning because your collection comes at 11 o'clock in the morning. So hopefully assisting with demand and increasing efficiency there. And there has also been a pilot of bookable appointments in the walk-in centre, which has been very positive and is being and the capacity available for that's being expanded at the moment. So those are some of the steps we're taking to help meet some of that urgent demand across the city where practices don't have sufficient on-the-day capacity. I included, for your interest, some charts and information on growth over time in terms of the sort of volume of, in terms of demand, so the number of appointments offered by practices, and also how they were being delivered, both in terms of how many patients were being seen within 24 hours, within a week, and also the mode, so the sort of changes in face-to-face versus telephone, just for information.
That's great, thank you. I've got Councillor Belbin's indicated you've got a question.
Thank you. You presented there the mode of appointment as a matter of patient choice, and I just wondered to what extent is it about patient choice? And I'm just drawing on very recent experience where I had the rare cause to see my GP. Very pleased that I got an appointment the same day, but I was more than happy to have a telephone or online appointment, and they required me to come down to the surgery. Not a problem for me, but I just wondered. Yeah.
So I think mode of requesting an appointment is very much, or should be very much patient choice, whether you choose to request an appointment, contact your practice by phone, walk-in or telephone. How your appointment is offered, so the actual appointment itself, a lot of that is actually about clinical opinion about whether you need to be seen or whether that appointment can be conducted by telephone. I think if you have a strong preference, then obviously that can't always be met, but patients can say, you know, if you would rather be seen by phone because that's convenient, you know, patients should certainly say, you know, if possible, can I have a phone appointment rather than a face-to-face appointment, or vice versa. But obviously practices will try and keep their face-to-face appointments for those who they think clinically need them, so it may not always be possible to have a face-to-face appointment if it's not clinically necessary.
Thank you. Councillor Mallinson.
Thank you. Yeah, just on those charts, which are on page 14 for everyone's information, the growth is it looks very subtle. They look reassuringly stable, to be honest, but it's sort of only over 2 years, so maybe it would have been nicer to have a longer time period to see how it relates to historically. But I mean, looking at that, if I was to put a best fit line through that sort of up and down line, it's probably about 5% over 2 years, which, I don't know, maybe it's quite a lot or maybe it's not, but it does look very, very steady. But I presume you're anticipating it to sort of shoot upwards in the future when more accommodation is built.
So you're right. One of the problems is the methodology for counting GP appointments changed. So it's difficult to take this back pre-COVID in a way that we can be sure is completely robust. Which is why at the moment you've got this data. I'd be happy to have a look at at producing something that goes further back. What we did see broadly was a sort of step change in demand post-COVID, or towards the end of COVID and post-COVID, which hasn't declined. I think it has flattened off somewhat. The other thing I would say is what you're looking at here are appointments, not demand. So what you're looking at here is to a certain extent limited by the physical and workforce capacity of practices and their ability to create, you know, to reconfigure, to redesign services to create additional capacity. And that's what you're seeing with the 5% growth. It's what practices have been able to add on, what we've been able to support practices to add on to their existing level of capacity.
So it would be interesting to see if that data is collected, how many people have actually asked for an appointment and not got one, for example.
We are starting to be able to see that because of the increasing use of online consultation and because of the move from analog to cloud-based telephone systems. Practices are increasingly able to work with the data that generates to understand what their demand is and to understand when they have peaks and troughs in demand so that they can re-engineer staffing cover and services to better fit with that demand.
Finally, the only sort of, in that top chart about the general practice appointments, the only pattern I can see, which is a bit weird, and I don't know if you've got an explanation for it, is there seems to be peaks in October of each year. The first one in October 23 is slight, but then there's quite pronounced ones.
Those are
the following 2 years.
Probably artefacts which it's hard to smooth out on this data caused by flu vaccination. So it's the initial spike in people booking flu and COVID vaccinations for the winter campaigns.
Thanks.
That's reassuring, isn't it? Could I ask a bit of a question about the data? Because you say 46% of patients were seen on the same day as of November 25, and then 78% within 14 days. Is there like a target that you aim for? Do you know, is that what you would expect, I guess is what I'm asking?
There isn't a target. We do compare that with the national average, and we're very close to that. So there isn't a specific target that we're working towards, but obviously we would expect it. I think it's hard to know at the moment because it's hard to know what would be the right balance at the moment. I think we need. This needs to have the broad adoption of telephone and virtual consultation. I think needs to have been in place for longer for us to be able to form a view on what the right balance between face-to-face and telephone is. But it's something we continue to review.
Great, thank you. Councillor Baker, did you have a question?
Thank you very much, and thank you, Abigail, for your report. It's very interesting. As we're going forward now and we're having more telephone appointments, and we're doing digital conversations and things like that, it's opening it up for people who are restrained by time or active or mobility. What I am finding is the comments we're getting is people are not able to pop into their medical centres and make appointments, and they're told they need to make a phone call or go online to make an appointment. That seems a bit of a retrograde step, really, when we're making such big inroads in other ways. If someone like me, the fact I can go online, make comments, and my doctor will come back to me and say telephone appointment, because I get to tick my preference anyway, telephone appointment or in-person appointment, and then somebody will come back to me and say, well, the doctor wants this. That's fine, that's brilliant, in fact. Saves a lot of messing about for a lot of people. But we don't want to miss the other people out, the people who wander into the GPs on the way to the shopping centre and like to go and book their 3-monthly appointment and they're told they have to go on the phone. So I think we should not go back forward too quickly and lose something off the end.
So are you saying that you're hearing from people who say that they've physically gone into the practice but been told they can't do what they want to do in person? The GP contract makes it clear there should be parity of access by all three modes, which means that it doesn't matter whether you should be able to go into your GP practice, speak to somebody. They may walk you through filling in an online consultation form, do that for you, and tell you you'll hear back. But they shouldn't. But you should not be told that you can't. You have to phone up. So if people are hearing that, they can pick that up with their practice or come through to the ICB, and we will collect that feedback and pick that up with practices. It shouldn't, patients should be able to phone their practice, go online, or walk in to make an appointment.
Right, now that's interesting because 2 of us in a row have experienced that.
Okay, well, if you want to, Alice has my contact details. If there's anything you'd like to pass on to me, then.
Thank you.
Thank you, that's great. Councillor Milson, do you have a question?
Thank you. Yes, Councillor Baker, I've heard the same thing from people who may be using the same route as you. I've heard the same thing anecdotally from patients, that you have to go online and there's no other option. So it's very interesting to hear that the contract specifies. And that's useful information actually for us to be able to tell people as well, if it is specified.
We know there are people who are reluctant, are unhappy that practices are using online triage forms, which is something different. Your practice can use that form because actually that standardises the process regardless of which route you're choosing to access them, but you should be able to access it by any of those 3 routes. So that is something we obviously need to make sure we are reiterating.
And with that in mind, is there? I mean, obviously, I think we're fortunate in Sheffield that GPs do talk to each other a lot. I don't know how this compares to the nationwide picture, but we have what seems to me a very healthy, communicative community of GPs, and we have primary care. We have forgot what they call it, Primary Care Sheffield, as a collaborative that really does communicate and discusses strategy and forward thinking together and innovation together. And I don't know whether that exists in other places, probably does. Manchester, I think, there's a similarly strong community of GPs. And that means that it's even more sort of surprising when you hear something, an anomaly like that, really, that you think, well, is there a practice that's kind of sitting outside of that very collaborative kind of way of working, and is that something that can be addressed? And I don't think it's appropriate that anybody should kind of impose this is how it will work in Sheffield, because it's happening organically, but maybe some practices could be encouraged to take part in that more.
Supported.
And maybe through the neighbourhood model, that's something that could happen.
Absolutely, and I think you're right. We do have a very good community of, a strong community of general practice in Sheffield, and a lot of really great work happening. And it's how we can make sure that we are sharing, either the ICB or, as you said, Primary Care Sheffield. We also work with the local medical committee, obviously, and through that, and through the GP Provider Forum, how we can share that good practice and help people who want to access that good practice as well.
Thank you. I just wanted to, you mentioned this very quickly, Abby, and I'm sure there's a lot more to it than just a quick mention. A pilot for bookable appointments at the walk-in centre. Yes. Now, I mean, I had a bad experience at the walk-in centre, not their fault. It was just a bad time because it was when scarlet fever had broken out, and and I couldn't get a GP appointment, so I went to the walk-in centre feeling quite poorly. Found a 6-hour wait, quite unusual, very unusual to have that amount of wait. But it did raise questions at the time. This is a couple of years ago, and it did raise questions at the time about how capacity is managed at the walk-in centre. And loads of people were saying, well, can't you take a ticket and then, if it's going to be 6 hours, can't you take a ticket and then go home and rest for 5 hours of those 6, not have to sit in that grim kind of everybody coughing at each other situation. And so this sounds like good, but I'm very cautious about saying good, because you should still be able to walk in.
This is the ability for GPs. So patients can still walk in. It's still a walk-in centre, but this is about how we maximise available capacity across the whole system. So having some appointments there that GPs can book patients into after they've maybe seen them earlier in the day and think they need, or can't see them and think they need to be seen on the day.
Makes me a bit nervous.
In what way?
That people just walking in on their own volition to the walk-in centre, there are going to be fewer appointments available.
No, this was around. This is definitely not about adversely impacting patient experience if you walk into the walk-in centre. It was about can we actually explore using some capacity that might not have been used slightly better. Yeah. It definitely isn't about diluting capacity for walk-in patients.
Great, thank you. Laura, have you got a question?
Thanks, Abby. At Healthwatch, we do hear a lot and have done for years about difficulties with availability of appointments and booking them. We also hear that different things work for different people, so patient choice is a good thing, but a lot of people don't know they have a choice. Is the other thing that we're finding out when we're talking to people, and as people have already said, we're also hearing that admin staff in practices are sometimes directing people towards the digital options, even though they do have a choice. And we know that there has been some issues in Sheffield with the use of digital platforms, especially for some specific groups, like people where English isn't their first language, people with learning disabilities and serious mental illness as well. So there could perhaps be some work done around that, because these people are already at risk of health inequalities, and improved access is something that should be being addressed. Also, the You and Your GP guide is great, but I'm not sure if there's any work being done to promote that more widely to people in Sheffield, because at the moment it's just a link on the like at the bottom of the web page of GP websites. People won't know what it's about, or it's quite easily missed. I think it's also not suitable for everyone. There's no easy read option, for example, so there could be some work to sort of help promote that.
Yes, and I think we find Healthwatch, Healthwatch feedback and the reports that you compile very helpful in terms of hearing views from patients on a monthly by monthly basis. I certainly sort of review all that and respond. I think probably what might be easier is I'd be happy to meet separately and have a conversation with you about some of that feedback, because some of it's actually about, are there particular issues we need to address, and is there particular communications that it might be helpful to put out, and what might be the best way of doing that. So I'm really happy to organise something to have a conversation with you, if that's helpful.
That would be great, thank you. Can I just ask one more question? Obviously, the move to digital is happening, it's going to happen, but what sort of work's going on in the city to support people around digital inclusion?
So there is a colleague of mine is working on digital inclusion across the whole of South Yorkshire. I haven't brought all the details of that today, but we can provide some more information on that. Obviously, we are aware there's two issues, isn't there? One is making sure that if you aren't digitally literate or don't have easy access to smartphones or whatever else, you aren't excluded from services. But there's also the piece about how do we support people to become more digitally literate in the health sense? How do we increase uptake of the NHS app? And there has been quite a lot of success actually from some individual practices who have used approaches. For example, I can think of one practice whose members of their patient participation group sat in the waiting room during surgeries and actually had sort of approached people and asked, how did you book this? Did you know you could do it this way? Have you got the NHS app? Would you like me to help you download it? Show you how it works? So there have been a number of things that have happened that have been, that have showed really quite good results in terms of uptake of digital. But that area around digital exclusion or digital inclusion is one that we are obviously really aware we have to we are aware and working on quite closely. So I can provide some more information about that. I just don't have the details with me today.
That's great. Thank you. Councillor Mallinson, did you have a question?
Yeah, the conversation's come back to what I was going to ask about, which I was reassured to hear what Councillor Milsom said about, and yourself, about the community of GPs in Sheffield, which is great, obviously, and it's obviously a means by which hopefully you can disseminate information about. You really shouldn't be digitally excluding people at the front desk of your surgery, you know, and remind us about that. So hopefully that's what you're going to do. Yeah.
Yes.
Thank you.
Thank you. And then Councillor Lee, did you have another question?
Yeah, I think some of my questions been asked is about the digital inclusion. I know some people will embrace all that and they'll embrace the different modes of consultation because it's convenient, it's quick, and they just want a quick answer because they know that's appropriate, and if they were really worried about their health, they would seek another form of consultation. But I'm just thinking about people who are not just digitally excluded, but people where, again, where English is not a first language, when they can't even get an interpreter when they go to a GP service, there isn't an online. I'm thinking of particularly the Somali community in my area. There's no interpreter available for that particular group. Some people can speak English, obviously, but it means other people have to take a friend, take a child.
Can I just clarify that? We do commission an interpreting service, which is accessible to all practices in Sheffield. Obviously, then, we know that there are certain languages where all interpreting services struggle to get sufficient interpreters, but we commission a universal interpreting and translation service which is accessible to all general practices in Sheffield.
I think there's some where maybe it is more difficult, but and I know my MP has written to the primary care services about that, the lack of maybe interpreters for the Somali community, but I will go back and check what the answer was to that one. I think it was different to what you're saying, but I will go back and check. But there are still people who will rely on a child to be around to do a telephone conversation because of those differences in.
We would not expect that. We would expect a professional interpreter to be used for all healthcare interactions. It is definitely inappropriate to be using a child to interpret in a healthcare consultation.
Okay, I will check what I've got in my email box.
Okay, if you have anything, then please do share it.
Thank you. Councillor Postlewood.
Thank you, Chair. We are obviously aware of the ongoing large changes to the NHS Integrated Care Board with the government's cuts big cuts around staff. Is the progression of this work, particularly around the hubs, protected throughout that process, and how will the progression of this work be affected?
We've got one hub which is nearing completion. We've got two we have planned for. We have costings within that for a programme manager to oversee to actually manage the delivery programme for that. So I think we can assume with a reasonable degree of confidence that those programmes will not be adversely affected by those changes. However, as you say, there are going to be significant changes overall to the structure of the ICB.
Thank you. Councillor Mallinson.
Just on that, what's the timescales for knowing what's going to happen to the ICB? Do you know?
It's just to interrupt. It's not a question for Abigail.
All right.
This not. Yeah, if we could move on, I think that might be better. And
thank you.
Oh, fair enough. Sorry.
And yeah, we're going to discuss it in the work programme section as well.
Yeah. Okay.
Is that all right? Did you have another question?
Yeah, I did. Yeah, and I bet the answer's going to be no to this as well. It's just Councillor Lee was talking about translation services, and I was thinking, well, better than nothing. You know, IT does provide translation services. You know, is it? I mean, this maybe not in a sort of formal consultation, but at the front desk, is a room for encouraging people to use something like Google Translate just to get the meaning across of what they're trying to tell them?
There are certainly programs that are being explored which would offer that form of digital translation. Obviously, you've got to be assured that the vocabulary within those tools is sufficient. Yes, we are aware there are a number of online tools now that you can basically have sitting on the desk in theory during a consultation, and it will translate. So there is definitely a lot of interest in that as an option, on top of telephone translation and face-to-face translation where that's necessary, interpreting where that's necessary. So yes, and also the increasing ability for certain online consultation tools for you to be able to submit that in the language of your choice, and for it then to be translated for the clinician.
Thank you. Councillor Baker, did you have a question on this point?
Just information, Chair. I mean, in the NHS, we've been using telephone, and I'm trying to remember the name of it for a long time, where we've rung up a service, said the language, the phone's been on the desk, and you can have a conversation. Not so easy when the person you're having a conversation with is on the end of the phone, obviously.
Yeah.
And very costly in some cases. And of course, the NHS budget's as tight as it is. And when I was working at an NHS hospital in Sheffield, we worked very hard to try and find something that was cheaper. But we had to, perhaps a good job, I can't remember it. But we maintained the one we did because people on that line had medical knowledge, and they could access most languages. That's why it was probably the most expensive. But there, you know, I have used my phone to talk to somebody in a different language very successfully with some casework, and I was amazed how well it worked. So there is light on the end of the tunnel, but just at the moment I think we're not quite there, and it's something that we've got to decide if we're prepared to invest in that. Yeah. Thank you, Chair.
Thank you. Councillor Milson, did you have a question?
Thank you very much. So I think what the only thing this report doesn't sort of touch on is patient feedback and the satisfaction survey and so on. And, you know, the STAR publishes every year, doesn't it, the results of the patient satisfaction surveys and does a league table of practices and so on, but that doesn't really explain any context or mitigating factors that might affect a practice's score that year, or ongoing improvement plans that might be in place, or innovations that are forthcoming. So it's very lacking in context and just a bit kind of raw when that's published. So does the ICB have a role in evaluating patient feedback and the results of the satisfaction survey every year? And like, do you work at a kind of strategic level with Primary Care Sheffield or individual practices to address any deficiencies or identify strengths and best practice that could be replicated elsewhere, that sort of thing?
Sure. Definitely, and our Primary Care Committee in Sheffield receives a report on the GP patient survey results as soon as they're released, or as soon as we're able to process them after they're released. So they can consider that and the overall position. We also we try and draw on multiple factors when we're looking at patient experience. The GP patient survey being one of those. There's obviously information from complaints, information from the CQC. There is another survey, the health information survey, which has very, very small sample and isn't available down to practice level, but that's something that increasingly we're seeing sort of NHS England are interested in using, and we hope that will evolve, obviously, because that tracks patient experience over time. But yeah, we definitely look at GP patient survey. My one caveat with GP patient survey is the sample size. It's probably the biggest sample size we have for a patient survey outside going to do a specific survey. But when you look at it, it is very small. So extrapolating from that, you know, the margins for error on that are huge. So you have to treat it with a degree of caution and look at what it's saying overall, rather than, I think, digging down to sort of individual individual factors. But yeah, it's definitely a tool we use, and it's definitely part of what we look at when we're engaging with practices.
And do you work directly with Health Watch on that front as well for feedback?
We haven't. Yeah, we actually have a member of Health Watch on our primary care committee, in attendance at primary care committee. So we really value that input and that engagement.
Great, thank you. Are there any further questions? Laura, yeah.
Yeah, just going back to the very beginning of the paper, I know we're not having an update on the neighbourhood health model and strategy today, that'll be at a later date, but could you tell us when that will be taken to the Sheffield Health and Social Care Board? And also, could you tell us how patients and the public have been involved in developing that model and strategy?
So at present, it's very high level. So obviously it draws on the patient experience and feedback we have gathered through a number of routes. But obviously, as this progresses, there will be greater patient involvement. It is my understanding at this point that it will be taken to board at the February meeting, subject obviously to any changes on the agenda or the plan.
Councillor Nelson?
Sounds like it would be something that this subcommittee might be interested in when it goes to the patient involvement kind of stage.
Yeah, I think the plan is for it to come here, isn't it? So
is that already a plan?
Yeah,
that's great.
so that'd be great. Any further questions? No. Thank you so much for coming today.
No problem.
And yeah, did you have another question?
It was just a comment, really.
Yes.
And absolutely, I mean, brilliant today, Abigail. Thank you so much. And it's a very concise report, but we seem to have, unpacked quite a lot from it, so that's really good. But I also just think it might be useful and very interesting for subcommittee members to have the chance to discuss some of the things we've touched on today with practitioners as well, and actually maybe have a discussion with some representatives of Primary Care Sheffield and the walk-in centre and so on, and actually see things from a different angle, really. Because today we're talking to the Commissioner and we haven't talked to any practitioners.
Perhaps when we could think about how to do that, perhaps Abigail, when you came back with the neighbourhood plan, we could maybe see if there was some primary care practitioners who'd be happy to come and join you at committee to sort of bring some of that sort of lived experience, perhaps, if you couldn't have a chat about that. But I think that'd be really good. Great, thank you so much. Brilliant. So we'll move on to the next item of our agenda, which is our work programme. So I'm going to hand over to our policy officer, Alice, who's going to take us through some of that. Thank you.
Thanks, Chair. Yeah, I've been having a look at it and making notes from all the things that everyone's raising today as well. I'll start by reminding you, you've got a long list of items that some have been scheduled, some have had to be postponed and will need to be rescheduled. There is only one more meeting this municipal year of this committee, and I think it'd be good to know what's a priority for you from the things that are in there, but also to flag that, as you're aware, ICB are going through an enormous organisational change. So I think in terms of how much we can get from them this municipal year might be limited, but also that, yes, in there at the bottom on page 23, I think we've included an update on ICB organisational change and a briefing for yourselves for the committee. And in a recent conversation, that was felt that the best time for that was at the end of their consultation. And the timeline on that is not 100% known at the moment. So there are conversations ongoing, and it will, I think it is absolutely sensible that it comes here. It's probably going to be into the next municipal year, if I'm honest, but it's there. But there are quite a few other items, and I just wanted to flag that you were expecting a couple more today. around update on the implementation of continence review and reports around equalities. They will be rescheduled, and that's why I'm sort of saying to you, what's your priority for March, bearing in mind some of this, we can try and reschedule them, but it might be that a lot more has to fall into next municipal year. And I think there are a couple of reports of your own work that you've done around dentistry, adult autism and ADHD, and the plan is that subject to kind of getting to grips with them, at least a interim, if not a final report on those pieces of work undertaken as a review by yourselves as the committee, will be on the agenda for March. So you are going to have a bit of an opportunity to catch up on those as well. So you have, as I say, there is quite a long list. I'm open to a steer from yourselves as to what is really important, and I would caveat any of that with we will do our best, but we can't necessarily promise the things you would really like to see in March.
Thanks, Alice. That's great. Just looking at what's already penciled in for March, which is the winter plan review. I think that would be good to keep that in March if possible, because it seems like timely. There's no point reviewing the winter unless we do it promptly, I think. So I personally think it'd be good to keep the winter plan on. And then I think with the one that's TBC, Children's Autism and ADHD Pathways, I think we decided, hadn't we, that we'd wait for that until we'd round up the working group on adult ADHD and autism. So that would be my feeling on the stuff that's already on March. Councillor Milson, did you have a point?
I did really. It's the ICB. Obviously, there is the consultation ongoing at the moment, which is only between the ICB and the workforce.
Yeah.
And so, in a way, there's a limit, I guess, to the scope of a discussion at this point. But also, I'm aware that we'll enter the pre-election period, and it may be impossible for us to have a discussion at the point at which it does become relevant. So I wonder whether we could actually request a discussion in March before we enter the pre-election period, regardless of whether they've wound up the consultation. Otherwise, it could fall in the period where we're politically restricted, and it becomes very difficult to have that conversation. And I think there are some really important and pertinent questions that we need to be able to ask about what the future model might look like and how it might affect patients in Sheffield, and the ability for us to work as a partner with the ICB, and in fact the other partnerships that our work as a council depends on as well. And so I think they're quite urgent questions, and I understand that the ICB are likely to say we can't say anything because we're in consultation, but I think we can't wait for those questions to be too late and risk them being too late.
I'm happy to contact the ICB on behalf of the committee and say that we'd like to talk to them in a timely way. My understanding would be during the election period we could have a private briefing with them, we just couldn't talk publicly, is that correct?
Yes, but don't forget they also have PERT rules, so it might be that they're not able to, from their perspective.
Yeah, so I'll contact them and ask. That sounds fine. And then I think Councillor Mallinson was next, and then I've got Councillor Baker and Councillor Crossthorne who'd indicated. Councillor Mallinson.
Thanks, Chair. I think for the March meeting, we do need to move on if we're going to have a discussion and debate about the Palantir contract. I think that it needs to be sooner rather than later, because there's some urgency about that, because we don't want to be in a situation where more and more of the local trusts are actually fully engaging with that, which might make it hard for them to, well, the decision has been made basically, and we do want to hear from them before they make those decisions.
So I've got general agreement that we could ask the ICB to come to talk to us about the potential rollout of FDP and AI in Sheffield. Would everyone agree with that in March?
Yeah, Chair, for me, I think that's something that we'd absolutely support. Lib Dem MP in Parliament, Martin Wrigley, raised an early day motion about concerns about Palantir and FDP, the implications of those, contracts held by people that don't share British values in protecting NHS patients as data holders. So I think that if that could come sooner rather than later, I think that would be an urgent and pertinent thing to discuss. That was one of the things I wanted to raise.
Okay, so yeah.
Could I make a suggestion about that then? That because I think we all need to understand what's going on with that. So I mean, I've done my own bits of research trying to poke into what it all means, because Dr. Gibson's come twice and raised it to us now. So I'm trying to take it very seriously and actually research into it. But of course, I can only find the information I can find, and I think it would be useful for us to reach a point of committee members understanding what it is we're actually looking at, and do some proper research around it, and then potentially be prepared to take some kind of view on it at the March meeting. But the stuff we need to do probably pre a committee meeting to help us understand what it is we're talking about.
Yeah, we can consider that. Yeah. Okay. And then Councillor Baker.
To change the subject entirely.
That's fine.
To say that I've recently become aware that there is, in my opinion, a crisis in what I believe is the right word, audiology in this city. To get a hearing aid for the first time through the NHS, you're lucky if you get one after a 2-year wait. If you have hearing aids and you need to replace them, they're not appropriate. The shortest waiting time is roughly 2.5 years. So we have a lot of patients who have obviously been diagnosed with an issue that can either go private and pay over £3,000 for some hearing aids, can buy something online that nobody really knows about, or have an extremely long wait. They say it's because of capacity after COVID. But I really think it's something that this committee could look at and possibly make a difference.
Thank you, Councillor Baker. I'm aware of that as well, and I think that could be something we could include in our work programme. It might not be to the new municipal year, but if everyone's in agreement, we can add that, definitely. Councillor Costhorne.
Thank you, Chair. Just to stress that as well, due to obviously the impact that hearing loss has on memory loss as well and dementia, I'd be quite concerned about the impact that's having on the wider system as well. So just to stress that from Councillor Baker. To again change the subject entirely, we do obviously have the Winter Plan review coming, where we do often talk a bit about immunisation strategy, but as the UK has just lost its measles eliminator status, and we do often ask quite a lot of questions at this committee when reports like that come about immunisation. Could we perhaps look in the next municipal year for a dedicated item on immunisation strategy overall, just because I think a dedicated item with the recent loss of our eliminator status of measles is probably quite pertinent. And then again, to change the subject entirely, we did discuss briefly at Adult Health and Social Care Policy Committee yesterday about the identification of carers, particularly through primary care. I should have raised it earlier thinking about it, because perhaps that could be something that can be stressed through the update we have around the neighbourhood plan, just so that we're not adding something completely new on top of our already pretty full work programme at the moment. But I think that's something that's worth stressing, because we're often talking about identifying carers and how we do it, and I think members would like to see what's changed and what is what's there to go forward to help with that.
That makes sense. Is everyone okay with that? And then there was also the point that was raised in one of our public questions about bringing a item on the work programme next municipal year about bereavement support in Sheffield. Would everyone be in agreement with that? So my suggestion for March then is we have we looked at the Winter Plan review, the Federated Data Platform and AI item, and then potentially we're going to be having an update on the working groups, aren't we, or one of them. And then in terms of the other items that we've discussed, which is audiology, immunisation, and the bereavement report, we look to schedule those probably for the new municipal year, and I think probably whatever form this committee takes at the beginning of the next municipal year, it might be good to have a briefing offline where we just sort of have a look at what's on the work programme and sort of prioritise it, but I think we can wait to do that till the beginning of the municipal year. Does that cover everything, Alice?
I think so.
Is everyone happy? Thank you. Brilliant. Councillor Milson.
Sorry, could you just say again what's in the March meeting?
So what's definitely in the March meeting is the winter plan review and the item on the federated data platform and sort of AI more widely in the health system, and also hoping to wind up those working groups on adult ADHD and possibly dentistry. Those reports coming to that meeting, and that'll be that, I think, for that meeting. Councillor
So
Musson.
no, I'm still concerned about the ICB.
Oh, and that's a briefing for members.
Okay, but I do think we should allow ourselves the possibility of being able to say things publicly if we need
Yeah,
to.
if we could, yeah, if it's
So again, pre-election period will delay things till
It
the
will.
end of May, and that could be then not very timely for things that we might want to say publicly.
yeah, I appreciate that. Yeah. Okay.
Also, continent services.
Yeah.
Very frustrating. This is years and years old, this work, and it's being put off
We could
and,
try
and
for
put
that
off, and it's.
and we could go back to them.
Yes, I think between me and Deb, we are still trying to encourage them.
I mean, it's a
Yes,
report
I
from
appreciate it's a very long report.
pre-COVID. It's never been signed off and wrapped up, has it?
Yeah, I would like to see that come back so we could wrap that up. Definitely.
I think certainly we would as well, because at the last report we got also was kindly delivered by Dr McMurray, but that wasn't someone that's particularly close to the service, and we do need to have a look at that because it is having a really key impact on patients, and we've had people come to this subcommittee to ask questions about it, about their relatives that it's affected, so I think we really need to stress that, if that's okay.
Brilliant. So that does bring us to the end of our meeting. So our next meeting, which is the last meeting of the municipal year, will be on Thursday the 12th of March at 10 AM. Thanks everyone.